Hello, welcome to the workshop, Long-Term Effects of Transplant Using Your Own Cells, or Autologous Transplant. My name is Lynn Spina, and I will be your moderator for this workshop. It is my pleasure to introduce today's speaker, Dr. Alfred Garfall. Dr. Garfall is an assistant professor of medicine and director of the Autologous Stem Cell Transplant Program at the University of Pennsylvania. Dr. Garfall's research focuses on evaluating new multiple myeloma immunotherapies. He is specifically interested in developing new approaches to prevent relapse in multiple myeloma patients. Please join me in welcoming Dr. Garfall.
Great. Hello, everybody. Thank you for joining today. I'd like to thank Lynn and all her colleagues at BMT InfoNet for the invitation to present at this wonderful patient symposium. I hope this is informative, and please do send in some questions as I go through the slides, and I hope to have an opportunity to answer many of them towards the end. So my goals are to give a very brief review of just what autologous stem cell transplantation is and what it's used for, and then discuss some of the major healthcare and health maintenance issues that arise for patients after autologous stem cell transplant. So I'm going to spend a couple slides going through who are our autologous stem cell transplant patients. And so you see here, this slide, this graph, tracks the number of autologous and allogeneic stem cell transplants that have been done over the years. And this is data collected from the Center for International Bone Marrow Transplant Research, which is an organization that tracks transplant activity across the US and the world, actually. And so you see here that autologous transplants, or transplants using your own stem cells, are currently, there's more of them happening every year compared to allogeneic stem cell transplants. And you see that the number of both types of transplants has grown over the years. There's an interesting story behind the shape of the green line, which is the number of autologous stem cell transplants. You see that there is a big increase in the 1990s in autologous stem cell transplants, and then an abrupt fall off. And this follows an attempt to use autologous stem cell transplant as a treatment for breast cancer that was initially promising, and there was a lot of increase in activity, the number of transplants done for breast cancer. And then some studies showed that actually it doesn't work. When you really put it to the test in big randomized controlled trials, it doesn't actually do any better than standard chemotherapy. So there is an abrupt drop-off in the number of autologous stem cell transplants. But then in the early 2000s, in the late 1990s, early 2000s, are where the first clinical trials came out, really showing that autologous stem cell transplant is helpful for multiple myeloma. And that has driven the gradual increase in the number of transplants performed throughout the 2000s. And I'll show you in a couple slides, multiple myeloma patients make up the majority of patients receiving autologous stem cell transplant. And then you see a little drop off in that trend in 2020. And though I'm not sure, I suspect that is due to a decrease in transplant activity during the COVID-19 pandemic. In our institution, we ended up putting a lot of transplants on hold, but in most cases, I think those patients went on to get transplants in the subsequent years, and I think we'll see those numbers go back up. So this graph shows the different types of diseases and the number of transplants performed for them. And so in green is the autologous stem cell transplants, and blue is the allogeneic transplants. And you see on the left here, the leftmost column, that multiple myeloma, which is a malignancy of plasma cells or plasma cell disorders, that refers to other diseases that are in the same family as multiple myeloma, such as systemic amyloidosis. These patients are the largest number of patients who receive transplants, autologous transplants. You see second in terms of the green autologous transplants are non-Hodgkin's lymphoma patients, and this is primarily diffuse large B-cell lymphoma patients. And you see Hodgkin's lymphoma makes up another portion of patients receiving autologous transplant. There are a couple other malignancies for which autologous transplant is sometimes performed, for example, germ cell tumors, which is not a blood cancer like lymphoma and myeloma. That's another reason patients sometimes get autologous transplants. And there are a handful of autologous transplants being performed for non-cancer diseases. So autoimmune diseases, diseases like multiple sclerosis or Crohn's disease, there is some experimental use of autologous transplant as a way to kind of reset the immune system in those immunologic diseases. This looks at the age of our autologous transplant patients over time, and you see that the group in the 65 plus age group has grown over time. And that also reflects the increasing use over time of autologous transplant for multiple myeloma, which is the disease of people typically who are over 60 years old, and also our increasing comfort in the safety of autologous transplants in patients who are in their late 60s and early 70s. And I think this slide is actually, I'm sorry, duplicative of one of the prior slides. Sorry, no, this is just focusing on the diseases for which autologous transplant is performed. And this kind of parallels some of the information I was showing you earlier, showing that multiple myeloma in the blue line really has been increasing over time in the use of autologous stem cell transplant. And non-Hodgkin lymphoma in the green has also been increasing, but not quite as much as it has been for multiple myeloma. So what are we doing in an autologous stem cell transplant? So an autologous stem cell transplant, the phrase, the transplant, makes it seem like the transplant is really the center of the therapy, but really it's the chemotherapy that is the center of the therapy when we're talking about an autologous stem cell transplant. Really the autologous stem cell transplant, which entails the removing of stem cells from your body before the chemotherapy and the re-infusion of them afterwards, the purpose of that stem cell transplant is to help the bone marrow recover from the effects of the high-dose chemotherapy. And really the transplant is just a way to make it reasonably safe to give really high doses of the chemotherapy. And it's the chemotherapy that we think is doing the therapeutic work of the transplant in killing the residual myeloma or lymphoma cells that are still in the patient after they've completed their standard therapy. So autologous stem cell transplants are typically undertaken in patients whose disease is under control from some prior therapy. So in multiple myeloma, that might be therapies like Revlimid, Velcade, dexamethasone, daratumumab, gets the disease under control initially and really reduces the amount of myeloma in the patient's body to relatively low numbers compared to where they started. But even in patients who go into what we call complete response, we still know that there's a lot of myeloma cells beneath the surface. And this high dose of chemotherapy as part of the transplant, the goal of that is to kill off some more of those myeloma cells to lengthen the amount of time that we can keep the disease under control. Likewise for lymphoma, so auto transplants are typically used in patients who have had some initial therapy for lymphoma and then have maybe had a relapse of their lymphoma, got some more chemotherapy to get the lymphoma under control. Perhaps your lymphoma is in a complete response, meaning you do a PET CT and you don't find any lymphoma, but we know that beneath the surface there are some lymphoma cells that are sticking around after that therapy. And so we want to come in with higher doses of chemotherapy to try and kill even more of those cells beneath the surface, with the goal in lymphoma of completely curing that lymphoma and really eliminating the chance that it could come back. And so those high doses of chemotherapy, if we were just to give those high doses of chemotherapy alone, they're such high doses that while hopefully they would kill some lymphoma and myeloma cells, they would also wipe out all the normal bone marrow cells. And if you lose all those normal bone marrow cells, your blood counts won't recover after the chemotherapy. So in order to make it safe to give these high doses of chemotherapy, beforehand we would take out from the body some of the bone marrow stem cells. And these bone marrow stem cells are like the seeds of the bone marrow that can completely regrow the bone marrow from scratch. So we take them out of your body before the chemotherapy, put them in the freezer, give you that course of intensive chemotherapy, which is usually melphalan in the case of multiple myeloma. And in lymphoma, there are some other different chemotherapies that are used, and I'll go through those in a second. And then after you complete those chemotherapies, a couple of days later, we re-infuse those bone marrow stem cells. And those bone marrow stem cells, just in the form of an intravenous infusion, can find their way to the bone marrow and start regrowing in the bone marrow. And while the blood counts will still be low for a couple of weeks after this chemotherapy, as those bone marrow stem cells take root in the bone marrow, you see the normal blood count start to come back. And that infusion of your own stem cells that was taken out before the chemotherapy, that really makes it safe to be able to give these high doses of chemotherapy without permanently wiping out the bone marrow. So I mentioned melphalan as the main chemotherapy that's used in transplants for multiple myeloma. In lymphoma, some other regimens of chemotherapy are used, often containing combinations of chemotherapy. So I've listed in black here the two most commonly used regimens nowadays, and they go by their acronyms, as you've gotten used to hearing chemotherapy regimens spelled out. So there's one combination called BEAM that contains 4 chemotherapies called BCNU, also known as carmustine. The E is for etoposide. The A is for Ara-C, which is also known as cytarabine. And the M is for melphalan. There's another combination called BCV, which is BCNU cyclophosphamide, and then a medicine called BP15, I think that's actually 16, sorry, which is etoposide. And then there are some other regimens I've listed here in gray that are not as commonly used nowadays, so busulfan and cyclophosphamide, or just total body radiation, which doesn't involve any chemotherapy but gives a dose of radiation to the whole body. That's not often used for autologous transplants these days. So as I mentioned, after those chemotherapies are completed, the stem cells are reinfused, and that's really the procedures in the transplant. Now, after the stem cells are reinfused, there's a period of time in the hospital for a couple weeks when the blood counts are going down and coming back up, and that's where some of the early side effects and toxicities of transplant come into play. And then there's a later phase of recovery after you leave the hospital, or after the blood counts recover if your transplant's not taking place in the hospital. So if we compare autologous and allogeneic stem cell transplant, these are really quite different in terms of the diseases that they're used to treat and the types of problems that can develop afterwards. And overall, autologous transplants are considered safer than allogeneic stem cell transplants. So there are, in allogeneic stem cell transplants, instead of that stem cell infusion being your own stem cells, it's somebody else's stem cells. And really, when you give a patient somebody else's stem cells, those stem cells are going to form an entire immune system in that patient that comes from the donor. That's a good thing in terms of that donor's immune system being able to fight off some of the residual cancer cells in the patient. That also leads to a lot of the complications that can happen after an allogeneic transplant, like graft-versus-host disease. In autologous transplant, we don't have to deal with those complications because the stem cells are the patient's own stem cells, and it's the own patient's immune system reconstituting in the patient. So we really don't see graft-versus-host disease. Very, very occasionally we see something called autologous graft-versus-host disease, but it's a much simpler condition when it develops compared to the graft-versus-host disease that develops in allogeneic stem cell transplant patients. And as a result, we don't have to give autologous transplant patients immunosuppression after the transplant, no tacrolimus or methotrexate or prednisone. And that overall reduces the risk of infection after an autologous transplant compared to an allogeneic transplant. However, in autologous transplant, the main issue that we worry about, and this is also a concern in allo transplant, but I think especially in autologous transplants for multiple myeloma, it's the underlying myeloma that continues to be a health problem for patients down the road after an autologous transplant. So when we do an autologous transplant for multiple myeloma, we recognize that in most patients, we're not going to cure the myeloma after that autologous transplant. Our hope is to put it into a long period of disease control where the myeloma is not growing and it's only present in the body at a very, very low level. We do expect for most patients eventually that the myeloma is going to start growing. Hopefully that's years down the road, and that you're going to need additional therapy for your multiple myeloma. And so the issues related to that multiple myeloma are really the primary health problems for patients long after an autologous transplant for multiple myeloma. In lymphoma, we also worry about relapse, although we hope in lymphoma patients that the disease is cured, and we do think of Hodgkin's and non-Hodgkin's lymphomas for the most part that are treated with auto transplant are typically curable, and we hope for that to be a cure in most cases of lymphoma. There still remains a risk of relapse that we have to watch for. And so we see overall with auto versus allo transplant, less transplant-related complications, more effects of the primary disease that you're treating, especially in multiple myeloma where we expect it eventually to come back. And then increases in risk of normal health problems that we see in healthy patients, cardiovascular problems, lung disease, things like infections and autoimmune disease, second cancers and effects on reproductive and sexual health. These are problems that are actually common in the general population that doesn't have cancer, but we do see some increases in the risks of these problems in patients who have had an autologous stem cell transplant. We're going to talk a little bit more about some of those as we go along. So when we think about recovering from an autologous stem cell transplant, you can think about it in two phases. So in the early phase, you're really recovering from the acute side effects of the chemotherapy. So I mentioned that these are high doses of chemotherapy. They all have an effect on the gastrointestinal tract in terms of your ability to take food and drink without, pains and diarrhea and nausea. We watch for dehydration. We watch for those blood counts to come back, and so in almost all cases, the blood counts do come back nicely as those stem cells take root, but we need to make sure of that, and sometimes occasional patients, it takes longer than we expect, and they may need some medications to support that. I mentioned that autologous graft-versus-host disease that happens quite rarely, and it's very treatable when it happens, but that's something that we're watching for as the blood cells kind of come back a few weeks after the transplant. We're watching for infections in this early phase, and so the immune system gradually recovers over a period of years after an autologous stem cell transplant, and the period where it's weakest is in the early couple months after the transplant. So we are watching very closely for infections. And we watch for gradually improving energy. So I always say that the two main side effects that we expect patients to have early after a transplant are gastrointestinal side effects and fatigue. The chemotherapy does just knock the wind out of your sails, and the period of most fatigue is in those couple weeks after the chemotherapy, but it really is a gradual process over a couple months that you fully recover your energy. And we expect most patients by about 3 months after the transplant to have recovered back to their baseline level of energy and vigor. And then there are some late effects that we think of playing out over months to years, and so there is some continued physical recovery. We still focus on infection, and we carry out usually a series of vaccines to boost immunity against common illnesses in the year or so after the transplant. And we also encourage patients to resume their normal health maintenance routines. And so typically, patients who go through autologous stem cell transplant have spent the prior year or so getting therapy for their cancer, where the cancer, the myeloma or the lymphoma, is kind of center stage in their lives. We hope by the time someone recovers from a transplant that the disease is under really good control and will stay that way for years. And so we encourage patients to get back to their primary care physicians, all the things that they might have been putting off for the last couple of years in terms of their routine health maintenance, screening colonoscopies, mammograms, skin exams, paying attention to cholesterol and blood pressure and blood sugar, some of those long-term health maintenance activities. We want patients to get back into those routines and start monitoring those other conditions again. Next slide. And while we're going to focus on some of the late, complications of an autologous stem cell transplant, I think it's important to mention that we expect most patients, the vast majority of patients, to get back to their prior quality of life after an autologous stem cell transplant. And that's always been our anecdotal experience in the patients we've cared for, but we've gotten in the last couple years some objective data that supports that notion. And so this is results from a clinical trial in multiple myeloma, where they were testing kind of a transplant now versus transplant later approach. And so if you look at patients who had gotten first-line therapy for multiple myeloma, half of them went right to get a transplant. The other half did not get a transplant and collected stem cells to maybe do a transplant years down the road. And in this clinical trial, they surveyed patients about their quality of life in a standard questionnaire at each step of their participation in the clinical trial. And so you see here in red the patients who got a transplant, and in blue the patients who didn't get a transplant. And as expected, around the time of the transplant, the patients who got a transplant had a decrease in their quality of life due to all the side effects of the intensive chemotherapy that I just mentioned. But you see here, by a few months after the transplant, these patients are answering these questionnaires in exactly the same way on average that the patients who never got a transplant did. And so they really are recovering to their prior quality of life as if they hadn't had a transplant by a few months after the transplant. And that is my experience anecdotally taking care of patients, many patients who have been through transplant for multiple myeloma, that we expect their quality of life to recover fully after the transplant. We do see for multiple myeloma patients who go on maintenance therapy with lenalidomide or Revlimid, which is the most commonly used medication as a maintenance therapy, a low-dose maintenance therapy after the transplant, that there are some side effects of that. And this is another one of those surveys where they surveyed patients over time as to their quality of life as they went through maintenance therapy. And you do see that there are some side effects of lenalidomide that do play out at certain time points after the transplant that affect patients' quality of life. I have to say that usually, and it's interesting that these kind of emerge early in the course of Revlimid maintenance, and then patients kind of go back to having the same quality of life if they weren't on maintenance. Because I think for most patients, we're able to manage those side effects as they happen with dose adjustments, but there is a period of time, you know, when you first start maintenance therapy after a transplant for multiple myeloma, where there's some diarrhea, fatigue, some effects of the Revlimid that we try to get around with dose adjustments and other supportive medications. I would say we're not successful in all cases, and regardless of what these statistics say, I know my experience with many patients is that there are really some chronic side effects to Revlimid in many cases, not all. And we make a case-by-case decision for patients, or with patients rather, whether they want to continue it for the benefits of Revlimid or whether they want to get rid of those side effects and consider stopping the Revlimid after some time. And these are some results from the similar study showing that as patients go through the course with their multiple myeloma and a transplant, that, you know, quality of life does improve after transplant, during transplant follow-up, and then you see some drop-off in quality of life when the myeloma starts growing again. And that just tells us that what drives patients' quality of life in the long term, at least in multiple myeloma after a transplant, it's the disease. We worry about the disease coming back, and that's the major health problem that people continue to have, even as we're going to talk in this presentation about some of the other medical effects of the transplant. So if you ask patients after a transplant, 5 years after an autologous transplant, what are some of the common problems that they report are common symptomatic and health problems? This is a list of the problems that more than 10% of patients in this survey reported. So sexual dysfunction, shingles, cataracts, osteoporosis or osteopenia, having to have a joint replacement, and skin cancer. And of course, these are problems that happen in patients in their 60s and 70s, even if they don't have myeloma and autologous, or lymphoma and autologous stem cell transplant. But nonetheless, we think probably a lot of these problems are more common in patients who have gone through a transplant. It's worth mentioning a couple problems that affect specific organ systems that are possibilities after a transplant. And so there are a couple problems that affect the lungs early after a transplant. So there's a syndrome called idiopathic pulmonary syndrome. Idiopathic in medical terms means we don't know what causes it. And so this is a condition of the lungs that happens early, usually around 2 months after a transplant. And it causes inflammation in the lungs and difficulty breathing. This is a little bit more common, I would say, with lymphoma than in multiple myeloma, and it's rare overall. Less than 5% of patients experience this, and this is usually quite treatable with a course of steroids. There is also a specific lung problem that can develop in patients who get a chemotherapy drug called BCNU or carmustine that is commonly used in the chemotherapy for lymphoma patients getting a transplant. Up to 20% of patients develop this usually within 3 months of the transplant. Your risk of this is a little bit higher if you've previously had radiation, radiation to your chest as part of your lymphoma therapy. If you got a higher dose of the BCNU chemotherapy, if you previously had bleomycin, which is one of the chemotherapies that's used in the initial treatment of Hodgkin's lymphoma, and if your age is a bit younger. The vast majority of patients recover from this if it happens, and it can be treated with steroids. Cardiovascular complications are another set of complications that can develop late after a transplant. It's not clear that these are actually from the transplant so much as the prior therapy for the cancer that was received. And this is really primarily a problem for lymphoma patients because lymphoma patients also receive a drug called doxorubicin, which is also called adriamycin, as part of their initial treatment for the lymphoma. So not part of the transplant, but for some of the pre-transplant therapy that lymphoma patients receive. If you've received chemotherapy regimens like CHOP or EPOC or ABVD, you've received some of this doxorubicin medication. And it's thought that this medication does increase the long-term risk of developing heart failure. And so heart failure sounds like a scary term, and heart failure can be a severe condition, but it's important to keep in mind that many, many patients have some form of heart failure. And heart failure, that is really kind of a bad term, because it connotes that something is really failing. Really there are many patients with heart failure or that diagnosis who can be managed with medications and have perfectly normal quality of life. But it does mean that that's a chronic medical problem that they have that needs to be managed in coordination with the cardiologist. And most of these cases, if they develop, they're milder cases, but of course there is some risk of severe heart failure that can develop with patients who have had doxorubicin, and that can develop in the later years after the initial therapy with it. There's an increasing appreciation of a concept called immune health, which is the health of the immune system. And we think of the immune system as being really important in fighting disease, but it also has a role in fighting cancer. And dysregulation of the immune system also is the cause of autoimmune disease. And in terms of looking at immune health long after a transplant, it's, as with heart failure, difficult to disentangle what's caused by the transplant versus what's caused by the fact that the patient had hematologic cancer, a blood cancer, and blood cancers are essentially cancers of the immune system, versus what was caused by prior therapy that the patient had before the transplant for their cancer. So nonetheless, though, if you look at patients who are long-term lymphoma survivors, you do see some deficiencies in immune health that's reflected in an increased risk of infection and autoimmune disease, even long after the disease has been cured, the lymphoma has been cured. Now, this was a comprehensive study that looked at this and did not find a big difference in these immune health parameters between lymphoma patients who did and did not receive a transplant. And so perhaps these late effects on immune health that we see in transplant survivors with lymphoma are actually from just the fact that they had lymphoma to begin with and had prior therapy for lymphoma even before the transplant. But nonetheless, in long-term transplant survivors after lymphoma, we do see these increased risks of infection and autoimmune disease compared to the general population. So how do we manage infection risk? So in the early phase after the transplant, we utilize preventative antibiotics. And so most patients will receive, in the early days after their chemotherapy, a host of antibiotics that are designed to prevent bacterial, fungal, and viral infections. And we treat fever very proactively in those early stages. And so we don't wait. If you have a fever in those early days after a stem cell transplant, we don't wait till we find an actual infection to start some more intensive antibiotics. We just give you more broad-spectrum antibiotics in that early phase to really prevent full-blown infections from developing in patients who have a fever. After patients' blood counts have recovered, in a couple months, starting a couple months after the transplant, we start thinking about long-term prevention of infection. And vaccination is an important part of that. There are also, for some patients whose immune systems are a little bit sluggish in their recovery after the transplant, we sometimes think of something called antibody replacement therapy. This is just like we can give a red cell transfusion or a platelet transfusion, we can also give antibody transfusions from other patients. This takes the form of a medication called intravenous immune globulin, which is a formulation of antibodies that's collected and purified from different donors, just the way platelets or plasma might be as a blood product. And that can be given as antibody replacement every 1 to 3 months after the transplant for patients who have not recovered the full antibody producing capacity of their immune system and are having trouble with infections. This is really a rare thing to have to go on IVIG after autologous stem cell transplant, but does happen occasionally, and it can be helpful for patients who are suffering from recurrent infections like pneumonias and sinus infections. There is a series of vaccines that are recommended after an autologous stem cell transplant, and there is some variation in practice, transplant center to transplant center, how intensively people are revaccinated and how intensive vaccines are given. The recommendations are the same from the guideline agencies for allogeneic and autologous stem cell transplant in terms of the number of vaccines that are received. And so this is the schedule that's recommended from the National Marrow Donor Program, which you can find at bethematchclinical.org, lists revaccination both with some childhood vaccinations, but also really focusing on the illnesses that are most common in adults. And this includes pneumonia, I would say, is the main one that we worry about. In addition, we recommend vaccination against shingles, and there is a shingles vaccine called Shingrix that has been specifically studied in patients who have had autologous stem cell transplants and been shown to be highly effective in reducing the risk of shingles after a transplant. And that's a 2-dose vaccine. We recommend avoiding the alternative shingles vaccine called Zostavax, which is a live vaccine. I don't think it's really around much anymore because Shingrix, even in the general population, seems to be the one that works best. Nonetheless, it is worth just keeping in mind that there are 2 out there, and the one that you want to get after an autologous stem cell transplant is the Shingrix one. And finally, a number of agencies, including the National Comprehensive Cancer Network, recommend repeating your COVID mRNA vaccine series after a transplant. So that's a total of 2 primary vaccines and 2 boosters after the transplant. I never like to, with COVID vaccines, it does seem like the guidance changes very frequently, and so this is what's recommended right now. It may not always be the recommendation, and I always advise patients and other physicians just to consult the latest guidance from the CDC, FDA, and the National Comprehensive Cancer Network for how to manage COVID vaccination in immunocompromised patients. So risks of other cancers late after an autologous transplant are also difficult to study because it's hard to disentangle what of that risk comes from the transplant versus the patient's prior therapy for cancer, and then whatever post-transplant therapy, like maintenance therapy in the case of multiple myeloma, might be causing. Some general guidelines are really to be diligent about your normal cancer screening for patients of your age group. And so you really do want to be diligent and not, it's easy to set this stuff aside. Let's just say that. It's easy to forget about mammograms and colonoscopies if when you've just been through such an intensive process for another health problem. But it is really important to stay on top of these things after your transplant. And so get back into the routines for normal cancer screening for your age. I tend to recommend yearly skin exams for my patients after autologous stem cell transplant, even though that's not necessarily a part of regular primary care. I do recommend annual skin exam to the dermatologist, and also staying on top of oral cancer screening, and that's usually part of your routine dental health maintenance that you should be doing every 6 months. And of course, really avoid lifestyle choices that increase your risk of cancer. So avoid smoking and enjoy the sun, but do it with sunscreen so that you don't get sunburn, which increases your risk of skin cancer. Some other problems that can develop, so thyroid gland dysfunction. About 10% of patients will have some degree of thyroid gland dysfunction. I do a lot of checking of thyroid hormone levels in patients because when you hear that patients are having some fatigue, you have to be mindful that they could have developed a hypothyroidism, and thyroid hormone is one of the main things that regulates our metabolism and energy level. Of course, fatigue is very common, and most patients who have fatigue do not have a thyroid problem, but it is worth checking just to make sure. And then peripheral neuropathy. And so this doesn't usually come from the transplant so much as the prior therapy that patients will have received for the myeloma and lymphoma before the transplant. But it can be made a little bit worse after the transplant, I've seen in some patients. The main drugs that we worry about that could have contributed to this from before the transplant include bortezomib, what's also called Velcade, a treatment for multiple myeloma, and brentuximab, which is a antibody-drug conjugate used in the treatment of some patients with Hodgkin lymphoma. Gabapentin is often prescribed to deal with peripheral neuropathy. I would encourage everybody to think about another medication called duloxetine, which also goes by the brand name Cymbalta. This, I think, has been pretty well studied in chemotherapy-related neuropathy, and in patients who don't get relief from gabapentin, or maybe even think about it as a first-line agent for patients with neuropathy, it can be very helpful. Next slide. Cataracts are, these are the development of problems with the lens in the eye. This is a very common problem in people as they age, but it's definitely worsened, I would say, in patients who have had a lot of steroids. And multiple myeloma patients and lymphoma patients all receive some steroids as part of their cancer therapy before the transplant, and that likely increases risk of cataracts. And so you should, if you're having some trouble seeing, go to the eye doctor. It may be cataracts forming, and just maintain some routine eye exams so that these are identified early. And cataracts can be treated with lens replacements, which are a very routine surgery nowadays. And then other problems, fatigue, depression, anxiety, cognitive dysfunction. These are all problems in cancer patients in general and really should be monitored and attended to. I'm not going into detail about some of the therapies for these, but you should not be afraid to bring these symptoms and concerns up to your physicians, both your oncologist, your transplant doctor, and your primary care physician. So as I mentioned, it's really important to return to routine health care and pay attention to some of the routine health maintenance parameters that all patients should pay attention to. So cholesterol, diabetes, maintaining a healthy body weight and regular exercise. In terms of bone health and risk of osteoporosis, maintain some vitamin D and calcium intake. So if you don't get this in your diet, think about calcium and vitamin D supplements. Follow your primary care doctor's guidelines for monitoring of bone density with DEXA scanning and treatment of osteoporosis if it's diagnosed. So fertility after autologous stem cell transplant. So most female patients after a transplant that either, depending on their age and perhaps being nudged along by the transplant, or even if they're younger and premenopausal, most female patients will be postmenopausal after the transplant. However, the potential to recover fertility after the transplant depends on age and the prior cancer therapy. And there are a minority of younger female patients who do recover normal ovarian function after autologous transplant. It's important to keep in mind that just because you're not having regular periods does not necessarily mean that you're infertile, so you should still think about contraception if you don't desire to become pregnant. And if you do desire to become pregnant, you should seek OB/GYN consultation in advance to receive some specific counseling about the risks and monitoring that you would want to undertake as part of a pregnancy. In patients who do get pregnant after transplant, there does not appear to be any increased risk to the health of the mother or the baby after the transplant. Male fertility is variable after a transplant. And for fertility preservation, this is easier for men for sure because sperm banking is usually feasible even in a newly diagnosed patient who hasn't started chemotherapy, getting that done prior to starting chemotherapy. Similar measures for females are more difficult because egg harvesting or embryo storage are more time-consuming procedures that take a longer time to plan and perform, and so that may not be feasible in a newly diagnosed patient who has a new lymphoma that needs to be treated urgently. So these should be considered on a case-by-case basis, and a lot of medical centers have obstetricians and gynecologists who are focused on this area and can consult with patients prior to starting therapy about some of these options and whether they're feasible. So sexual health, I mentioned, is one of the more common things that patients report problems with after a transplant. Both men and women report less sexual activity after the transplant than would be expected for their age based on surveys of patients who haven't been through transplant. Reported reasons for lower sexual activity among patients were reduced sexual dysfunction, so erectile dysfunction for men, or vaginal dryness for women, or overall reduced interest. These can be, sorry, I think the slide that I Yeah, so these can be addressed in the case of men for erectile dysfunction, use of medications like sildenafil, and for women, topical estrogens that can be prescribed by primary care doctors or gynecologists are often effective in alleviating vaginal dryness. I'll mention, as we come to a close here, one of the most common questions that I get from patients is whether diet matters in the long-term control of the underlying cancer, the lymphoma or the multiple myeloma, and how to kind of handle diet post-transplant. And I always have told patients, just maintain the same healthy diet, and that we don't really have a lot of information about which diet is better or worse for control of the cancer. At least in the multiple myeloma field, we really have some really interesting data from clinical studies that has emerged in the last couple of years from the group at Memorial Sloan Kettering Cancer Center that I think gives us the first hint of an interaction between diet and long-term control of the multiple myeloma, specifically in the post-autologous stem cell transplant setting. And what I think is good news about this is that it actually doesn't point us towards any special particular diet or special food. It points us towards actually just the same dietary guidance that we had been giving anyway. It turns out that there's some real evidence mechanistically that the kind of standard healthy diet that you hear about from the CDC, which is rich in fruits and vegetables, whole grains rather than refined carbohydrates, an emphasis on protein coming from fish and beans and legumes, not a vegetarian diet necessarily, but maybe a plant-focused diet, that seems to modify the bacteria that live in our guts in just the right way, and there may be a favorable interaction between that bacterial composition of our gut and the immune system's ability to fight off and maintain long-term control of the multiple myeloma. And so this is an emerging area, but I think we finally just in the last year have some real information or data as opposed to just kind of general guidance. But I think fortunately it points us in the same direction that our prior general guidance did, which is eating the same healthy diet that we all should eat, that may be helpful for your long-term control of your multiple myeloma also. So in summary, I would say even though we talked a lot about late complications, I think it's important to remember that most patients return to their prior quality of life after autologous stem cell transplant. There may be long-term impairments in immune health and risk of infection. And then there are perhaps increased risks of otherwise common health problems such as sexual health, bone density, and infections. Important interventions to maintain your health after an autologous stem cell transplant include vaccinations, getting back to your routine primary care, medical care, including cancer screenings and measures to address sexual health that I mentioned. And there may be an emerging role for plant-based kind of Mediterranean-style diet to potentially improve long-term multiple myeloma control. So thank you again for the opportunity to present, and I would be glad to take whatever questions have arisen.
Thank you, Dr. Garfall, for your excellent presentation. We will now begin the question and answer session. If you have a question for Dr. Garfall, please use the chat box on the left side of the screen to submit your questions, and we will answer as many questions as we can in the time allotted. So our first question is, what do studies show stopping maintenance versus continuing maintenance for a longer remission?
So that's a very good question. I assume you're talking about multiple myeloma there. This is really an area of uncertainty. I would say that we have the best evidence for maintaining maintenance therapy through a couple years after the transplant. Beyond that, it's a little uncertain. I would say the best data we have are from two clinical trials that had the same designs, but one was conducted in Europe and one was conducted in the U.S. And really the only difference between their designs is that in the U.S. they used continuous maintenance until the disease started growing again, and in Europe they kind of cut off the maintenance at 2 years. And it looks like from those trials that patients had better control of the myeloma if they continued the maintenance therapy beyond 2 years. But that still doesn't tell us about 2 years versus 3 years. 3 years versus 4 years. And in both those clinical trials, patients stopped maintenance therapy if they couldn't handle it anymore and they were having significant side effects. And so I still think our goal in the maintenance phase of therapy after transplant for multiple myeloma is for you to be able to get back to your normal quality of life. And so if you stuck it out for a year or two of maintenance therapy and you're really struggling with the side effects, I certainly consider stopping maintenance therapy in my patients in those circumstances and tell them that they've put an honest try in with a couple years of therapy. But if there's only mild side effects and you find them manageable, there's perhaps a hint in the clinical trial data that continuing it for longer may help with control of the myeloma, but exactly how much longer and for how long, we're not sure.
Thank you. The next question is, after stem cell collection, how many years do the frozen stem cells typically remain viable for a subsequent transplant? And this is a two-parter. What are the risks for the development of other cancers after a stem cell transplant? I know you mentioned about the skin cancer, but you might want to elaborate on that too.
Sure. So in terms of how long the stem cells last, different centers will have different policies about this, and I think it hasn't been extensively studied. Our center has felt comfortable using stem cells that have been stored for up to a decade. Sometimes if we're going to use stem cells that are older than that, we'll try to do another collection of fresh stem cells just to have as a backup. But the stem cells do last for years and probably a decade, if not longer. The second question related to second cancers. So I would say it is a little bit tough to study this question. I think in the context of multiple myeloma, we do think there's an increased risk of second cancers in patients who are receiving the transplant plus the Revlimid maintenance. There seems to be potentially an interaction between the Revlimid maintenance and the transplant that increases the risk of other cancers over time. Now, that increase in risk is small. It's only a couple percentage points. And we think in myeloma patients, at least, that the benefit of the maintenance therapy in controlling the myeloma, which is the main threat to our patients' health, outweighs the risk of other cancers. And that's been shown in the long-term clinical trials that on average, people who get Revlimid maintenance live longer with the myeloma than people who don't. So that tells you the kind of net benefit of the maintenance is worth the risk, that small risk of second cancers. And remember that a second cancer is not necessarily the end of the world. You know, a lot of these second cancers that have been reported after transplant, they might be early stage cancers like a skin cancer that can be removed with a minor surgery, or even an early stage breast cancer that can be treated and does not become a long-term threat to the patient's health. And so that said, there are some real life-threatening cancers that can develop after transplants, leukemias and things like that, but they're fortunately very rare. I can't quote for you the statistics, I would say off the top of my head, of patients, you know, in studies that have kind of compared transplant versus no transplant and the risk of second malignancies. But in those trials, I will say that the primary threat to our patients' health remains the underlying cancer that we're treating with the transplant. And so the concerns about second cancers are minor, and hence when you look at the long-term outcomes in the diseases where transplant is regularly used, it looks like getting the transplant has improved long-term overall survival for patients, such that the benefit in controlling the underlying lymphoma or myeloma outweighs the risks associated with the other cancers.
Thank you. This person writes, I lost over 60 pounds in my second stem cell transplant. I'm thinking they mean during my second stem cell transplant. Is that normal?
So I would say it's not common to lose that much weight after as part of a stem cell transplant, but there is often a substantial amount of weight loss. This varies from patient to patient. I've had a lot of patients who lose no weight, a lot of patients who lose a lot of weight. That's often related to just the effects on the gastrointestinal tract of the chemotherapy and sometimes infections that can develop afterwards. Most patients do recover. I would say our center, and I think a lot of others, have been a lot more proactive about using what we call parenteral nutrition. So patients who are having a real hard time eating during the transplant, switching over to nutrition through the vein, even if it's just for a few days, to prevent that calorie deficit from building up that leads to really loss of lean body weight and muscle mass when patients are kind of in the depths of the side effects from the chemotherapy. And so perhaps some of that more proactive supplemental nutrition has been helpful in mitigating some of the weight loss. But that is a real problem, but most patients do recover that weight with time.
Thank you very much. The next question is, how prevalent is secondary cancer for women in their reproductive organs? After 10 years post-autologous stem cell transplant, I developed breast and endometrial cancer.
So I don't have on the tip of my tongue the exact statistics about those specific cancers. Of course, breast cancer is a very common cancer in women, and so it's going to be the top of the list for any list of cancers that develop in women in any circumstance, either after an autologous stem cell transplant or not. So I'm sorry I don't have specific statistics on the tip of my tongue for that.
Okay. What about long-term fatigue and weakness? I am 4 years post-auto and struggle with significant levels of both.
So that's an important question, and I would say, I kind of showed you the average statistics for patients recovering their energy level and quality of life after a transplant. But of course, that's not everybody. Everybody is not in that average group, and there are, I think, outliers who continue to struggle with late complications or late fatigue. So if you're a multiple myeloma patient, I would think about, if you're on Revlimid maintenance therapy, what role that could be contributing. It's very safe from my perspective to stop maintenance therapy for a month or two just to see if that's the problem, because it really is with fatigue hard to sometimes disentangle what's the medication, what's lingering fatigue from the transplant, what's other factors or other health problems in my life. If you really, if it's not related to Revlimid maintenance therapy, there are some supportive things that I would encourage you to think about. And so there's a medication called methylphenidate, which also is called Ritalin. That's a medication that's used to treat attention deficit disorder in patients that have attention deficit disorder. It also, though, has been specifically studied in cancer-related fatigue, and I would put this kind of malaise and fatigue in that category. I've had a lot of patients who have been on myeloma therapy for years and have that kind of just cumulative fatigue. And it doesn't work for everybody, but there are some people for whom it's been a game changer in terms of increasing energy level. It's a very safe and short-acting medication. You can use it, on an as-needed basis. And so the standard routine that I recommend for patients is to take it in the morning and with lunchtime. And you can get effects even with very small doses, the same doses that you might use in a young kid with attention deficit disorder. So safe doses, and it's been studied for this indication. So I encourage patients to think about that if this is a problem.
Thank you. I also want to mention that we do have a workshop in this symposium week on fatigue, and we also have one on exercise. So you might want to tune into those and get some tips there. The next question is, do you recommend tandem transplant if you have high-risk cytogenetic factors?
So yes, that is I would say, there are clinical trials that point to potential benefit of tandem autologous stem cell transplant in patients with multiple myeloma and high-risk cytogenetics. We do not currently do that in our practice. The data supporting that, my understanding is that they primarily come from studies in Europe where the patients did not receive the same type of initial therapy for multiple myeloma that we typically give here in the United States. And so if you received our typical induction regimen in the United States of Revlimid, Velcade, dexamethasone, maybe with the addition of daratumumab, it's not clear with that more intensive first-line therapy whether 2 transplants is better than 1 transplant for high-risk multiple myeloma. That has not been shown in at least my understanding of the data from the clinical trials in the U.S. that have compared 2 transplants to 1 transplant did not show a substantial benefit even in the high-risk subset when they were receiving kind of what we think of as the standard first-line therapy for myeloma in the U.S. However, there are still, you certainly can read those trials another way. And so if your doctor is talking to you about a tandem transplant, it's not a crazy thing to consider. And there is certainly a lot of evidence suggesting that it's safe to do tandem transplant. And like I said, if you read clinical trials a certain way, you can potentially see some benefit for high-risk patients in those trials. So it is an area, I guess, of uncertainty. It's considered an acceptable thing to do if you look at some of the guidelines, like the NCCN guidelines. My personal practice, though, is not to recommend that.
Okay. The next question is, if having gastrointestinal issues 4 to 5 months out from BMT for lymphoma, when do I need to see a gastro doctor?
That's a good question. I would say it's not, 4 to 5 months out I would say it's not uncommon to still have some lingering gastrointestinal symptoms at that point, but you really do want to see that there is a trend towards improvement. So if they're getting better week to week and month to month, I think you can be patient with it. But if they're not getting better or they're getting worse, it might make sense to think about seeing a specialist like a gastroenterologist who may be able to think of things that are unrelated to the transplant that could be causing this, and also pursue some more advanced diagnostic procedures like endoscopy or colonoscopy.
Okay. Next one, if you still have neuropathy in fingers and toes a year after your transplant for non-Hodgkin's lymphoma, will it eventually go away without taking drugs?
So maybe, maybe not. I would say, and I would have some additional questions about when you first noticed it and how long you've had it. Peripheral neuropathy, I would say there is a good chance that it will improve with time, but there's also a good chance that it doesn't completely resolve. And so it makes sense, I think, to give it some time if it's not crippling and if you're averse to taking some medications. But I think that the medications that I mentioned for peripheral neuropathy, especially duloxetine or Cymbalta, it's not a long-term commitment to take them. You can start them. If it really helps you, you continue. If it's really helping and you want to see if you still need it, you can always stop a few months later. But I think it is also reasonable to just kind of watch and wait a little longer.
Thank you. We have time for one more question, and that will be, does stem cell collection impact bone health, such as increased osteoporosis in the bones?
I can't say I don't think I've seen evidence that the stem cell collection procedure has any adverse effects on bone health.
Okay, thank you. On behalf, this is ending our presentation. We are out of time, unfortunately. On behalf of BMT Infonet and our partners, I'd like to thank Dr. Garfall for a very helpful presentation. And thank you, the audience, for your excellent questions. I just want to make a note that some of the questions that we have left that are unanswered do relate to many of the different symposium workshops we have, like mouth issues and chemo brain. So please, since we haven't been able to get to all the questions, take a second look at the agenda and see if maybe one of those workshops would be good for you to listen to get the answers to your questions. Also, please contact BMT Infonet if we can help you in any way. That's help@bmtinfonet.org, and enjoy the rest of the symposium.